So these are the all list of flow cytometric uses. So what is this? What's the name of this plot? Anyone? Dot plot or the scatter plot? Fine. It has got two axes. Each axis is labeled. Something which is showing FSC means forward scatter area. The other says side scatter area. Fine. In the next plot, you see it's CD45 APCH7. It says that CD45 is an antibody. It is tagged to APCH7, which is a fluorophore. Dr. Jasmita must have told about different fluorophores that we use, and these are antibody tagged. So if you run a sample on a flow cytometer without using any antibody, this is what you get. So just like any other plot of a CBC analyzer, in CBC analysis also you get certain plots. This is forward scatter, this is side scatter. Forward scatter, Hemant must have told, denotes the size of a cell. So if a cell is lying over here, it will be smaller in size as compared to this. All these are the relationship, because you have, suppose you have a canvas. Now you have to draw each and every cell that you see in the peripheral blood of your sample between this to this. So if some cell is lying over here on an arbitrary scale of 100, another cell or dot is lying over here on an arbitrary scale of 200, this cell has got twice a size as compared to something which is lying over here, right? So this axis denotes the size, this axis denotes internal complexity or the granules, right? And if the nuclear is folded, scatter will be high. If granules are more, scatter will be high, fine. And when we use certain antibodies like CD5, 45, APCH7, now this is peripheral blood, what you see a group of population over here, a group of population over here, a group of population over here, some streak line thing over here, and some here. So roughly you can identify 1, 2, 3, 4, 5 cell population or group of cells. Now you don't know what exactly it is, whether it's RBC or WBC. If you don't know anything, just as a layman term, if I ask you, then everybody would agree that these cells are expressing more of CD45 as compared to the cells those are lying over here, right? And if I say that with my setting, anything below 10 to the power 2 should be considered as negative, then these cells will be negative for CD45. These will be bright positive for CD45 because these are lying farthest towards this side. These will be having something in between this and this, right? So moderate. And if you add the other property of scatter, these cells have got lower scatter, while these group of cells have got higher side scatter. Now close your eyes and think what cells you see in the peripheral blood. Give any one name. What are the different leukocytes? Somebody said lymphocytes. So lymphocytes have got high side scatter or low side scatter. Lymphocyte is a small cell, low side scatter. So this cannot be neutrophil. Why? Because my neutrophil should have higher side scatter. So that's how you interpret. Here you assume that this is my lymphocyte by lymphocyte because it is having higher 45 and lower side scatter. Similarly, these are moderate 45 and high side scatter because these are having high granules. And some streak-like things which are over here, these are the eosinophils, right? Which have got larger granules and they go very high. They lie over here. So if you take this population, the major population lies something from here to here. And these are the cells which are going off scale. These are saturating over here. So these are the eosinophils, fine? Very good question. So suppose if I have to compare my size to yours or my size to madam's, we are human, the range and the difference would be little. But if I want to compare the size of an ant to an elephant, my scale should be bigger, fine? So size doesn't matter. Lymphocyte is 7 to 8 micron, you neutrophil is 15 to 16 micron. The variation is twice or 2.5 times. So here you compare the linear scale, right? But in fluorescence, these cells suppose have got 3 lakh antigenic epitope of something on A cells, while these monocytes may have 5,000 or 10,000 antigenic epitope. So when you compare the variation of antigenic epitope or antigenic intensity, it varies in terms of 10,000 and 1 lakh. So just to accommodate these things, every fluorescence thing is taken on this, what you say, by exponential scale. Why by exponential? It's 0, so exponential over here, it is going backwards to 10 log minus 2, 10 log minus 2. So this is by exponential scale. So when you have to compare a large range, you use this scale, not the linear scale. Fine?
So, size scatter is only dependent upon surface.
So it's one term if you see internal, if you say internal complexity. Internal complexity can be in terms of presence of more granules. It can be in terms of more lobulation of the nucleus. Both these things can have, and both these things together add the neutrophils to lie over here. If the neutrophil is having low granularity or hypolobation, these will come down side. Fine. So it's a mixture of both granularity as well as nuclear complexity. So now a question or a quiz. I showed you this plot. Fine. Now, this is a different experiment looking similar. If I ask you how many color experiment this plot had, so in flow cytometry, you say that I have 3 laser 12 color experiment. Fine. So if I ask you how many color experiment or how many, the question is the plot shows that this is a 1 color experiment, 2 color experiment, 3 color experiment, what color experiment? 1 के लिए कितने लोग हाथ उठाएं? 2 के लिए कितने हाथ उठाएं? 3 के लिए कितने? मतलब 5 कलर, 6 कलर, or cannot say. So Dr. Jasmita and Rashmi madam are experts, so they say cannot say because we don't have sufficient data. Fine. So why I'm asking, why I'm showing this picture? Color does not mean color of these plots. Fine. Color means how many fluorophore you have used. So if there is a single fluorophore, APCS7. With APCS7, if I get 6 population, I put a gate around each of these populations, they will automatically get a different color. Fine. So I can have 100 of color with 1 fluorophore. That's not a 100 color experiment, that's a single color experiment. But why cannot say is the correct answer because I have shown only 1 plot. Maybe there are different plot which has also used CD8 in BB510, CD4 in P7. So we cannot say, but certainly this is not a 5 color or 6 color experiment. So the message that I wanted to convey for the beginners, many times it says that it's a 5 color experiment, meaning thereby you're seeing 5 different colors. It's not like that. It's the number of fluorophore that you use. So suppose in an experiment, just like many times we use CD19 with P7 as well as CD4 with P7. We club 2 antibodies together in a single fluorophore. In that situation, my experiment can have 10 color, 14 antibody tube, 12 color, 15 antibody tube, because 3 or 4 antibodies may have a common fluorophore. And why we use that? Just to save our money and save our fluorophores. Because if I know that 2 populations are mutually exclusive, cannot be together. An example which I gave, 19 and 4 together. So what we do first, we get out CD3 positive cells. Now, from the CD3 positive cells, whatever signal I'm getting in P7, that should be because of CD4, not because of CD19. Because CD19 is a B cell marker and CD3 and 19 cannot be together. Fine. So we get out CD3 positive cells and something signal which we are getting in P7. Those are because of CD4 P7, not because of 19. This, when you start doing multiple color experiment, sometimes you tend to collate these 2 antibodies together just to save money and time. Fine. So the message clear. Right. So now coming to a clinical scenario. Fine. This is 8-year male who presented with weakness and fatigue along with episodes of fever for 2 months, severe joint pains for last 7 days, inability to bear weight. छोटा बच्चा है, inability to bear weight, माँ बाप उसे अपने गोद में लेकर के आए हैं OPD to see a hematologist, and on examination the child is having average build, pale and having multiple cervical lymphadenopathy. ये history है. If I say this is the history, what is your first differential diagnosis? Important point to note, it's a child, severe joint pains, multiple cervical lymphadenopathy, and जोर से ALL. हाँ, yes, no. उसके अलावा क्या हो सकता है? If suppose I give this scenario to be related to immunology, what is the common diagnosis? JRA. JRA is one of the common diagnoses, fine. Patient present with severe joint pains, multiple lymphadenopathy, and so on and so forth. So what next you will like to do in this case? CBC with peripheral exam. So this is the CBC finding, TLC 32,000. You have a machine which says that you have got large and stained cells. So this plot is from the ADVIA. ADVIA is a analyzer from Siemens that gives some larger cells which look like blast, and they do not take myeloperoxidase stain on the equipment. They say that this is what large unstained cells. Fine. So based on this CBC, what is your DD? Come on fast, any guess? You have very high TLC and you have got large unstained cells. So more favoring towards ALL. And just I said, these all factors were done for the immunological point of view. So this is the peripheral smear. What is your diagnosis or what will you do? So what are these? So some cells which are having very high NC ratio, the granules in the cytoplasm is not very prominent. The size is roughly twice to 2.5 size that of RBC. And what is this? What is this? This is myeloperoxidase stain, fine. What I have shown over here is internal control, and these are the blasts which are negative. So you have abnormal cells in the peripheral blood, which are negative for MPO. What next?
Is it fish mouth like appearance in everyone?
This one.
No, this cell. Yeah. Fish
So
mouth.
these are mostly round, but slightly irregularity in the nucleus. And these do not look like lymphocytes because lymphocytes usually have a 2D flat kind of nucleus, something which looks like a 3D and mounting like. If you see, it looks like something is being protruded out and coming out. So this is not exactly fish mouth. If it would have been a 70-year-old patient, 60-year-old, then you could have thought of mantle cell lymphoma or something else. But the chromatin is not exactly like that. So anyways, it's a child. And we are saying this type of cell, which are MPO negative. What next would you do? Your suspicion is towards the line of leukemia. Fine. What next you will do? Bone marrow examination. Why bone marrow examination? Why can't you do flow with filtered blood? 36 doesn't make any difference. 36,000 count, you have 80% of these cells. Flow cytometry. Now question is, why immunophenotyping? Why you don't want to do flow cytometry? So the answer lies, you want to make a diagnosis and classify this disease. Whether it's leukemia or not, yes or no. If it's a leukemia, whether it's AML, BALL or TAL. That's your first job. Fine. Next thing, you got to know certain prognosis. You have certain markers, expression of A, B, C thing that will help you in leading out that this may be having a bad genetic mutation or having a bad prognostic thing. Fine. The other thing that you want to know, any therapeutic target. If you get CD20, CD22, CD38, you can use these targeted therapy in addition to the conventional therapy. Fine. And then you want to identify the phenotype of these blasts so that you can monitor them with the help of MRD analysis. Fine. So these are the broad 4 roles that you do with the help of immunophenotyping. And the question that I ask is, suppose you wish to do bone marrow expression and biopsy. You can also do the classification and immunophenotyping based on the bone marrow biopsy. You can do trifine, you put 50 antibodies, and you can say that this is a leukemia and this leukemia belongs to this type. But we prefer flow cytometry because of several advantages that we already know. 2 or 3 advantages can even tell. It's all written over here. It's a rapid technique, fine. Cutting it refine and getting UIFC will take not less than 3 days, even in a center that does it on a routine basis, on a fast track basis. But flow cytometric phenotyping, you can do it within 2 to 3 hours. Fine. Large number of cells are analyzed in a very short span of time. And most importantly, you can identify multiple antigenic expression on a single cell. Now we have tools for IHC as well, that it will do IHC, it will wash off antibodies, then second IHC, wash off antibodies. Now we have some high-end automated system for that as well. But even with that, you cannot say for sure that my this cell is expressing A, B, C, and D, and not E antibody. This is possible with flow cytometry. So because of all these things, you have got with the flow cytometry, you choose flow cytometry for flow phenotypic analysis of mostly blood and bone marrow because they are inherently in the form of fluid. You don't need to make them as a single cell suspension, fine? Other things, if in a sample biopsy, you crush, you mince, you tease them, you can make single cell suspension with that also. So broadly, these are the steps that you must be aware by now. And the thing that you need for staining these cells are the antibody panel. And how to make antibody panel, Dr. Desmita told about. So initially, this was some of the earlier panels. It's not clear visible over here, but this, if someone can read here, it is written anemia. So based on the expression, the presentation of patients, usually a set of antibodies were used earlier. That the patient is presenting with anemia and fever, use this antibody. If it is positive, it can be this. These are the number of labs that use these antibodies based on the clinical symptoms. So these were the initial antibody panel, but we became wiser little bit and then started having meeting to have consensus panel design. Fine. So the best validated and commonly used antibody panels, if you go and want to read it, are the Euroflow panels. They have validated across the center and they have good harmonization steps so that a center which is on the top and can perform 15 color antibody staining is not doing 15 color antibody staining because he has to take the other people as well. So they are sticking to a 8 color antibody panels, even if the lab is capable of doing 16 color antibody panels, just to harmonize the thing so that a result can be compared to your other lab. So this was done somewhere, I think, in 2010-12. Jasmita, madam? Yes. So this was some consensus panel that people came out with in India. Some lab followed it, but many labs don't. So this Euroflow consortium panel that I was talking about. And this is somewhere our panel that I'm showing. This is 10 color panel and somehow we are doing 10 to 12 color panel based on thing. So what is this panel? Panel is a group of antibodies that will help you in make what diagnosis. So my first point was how to make a diagnosis of acute leukemia. So you have to identify that your cells are immature. It's not mature because mature, the treatment of immature and mature is totally different. So your first job as a pathologist is to say to clinician that this is an immature neoplasm. So to prove the immaturity, you have certain markers, presence of CD34, presence of TDT, high expression of 99, or absence of CD45. These are 3-4 things that will help you to say your clinician that yes, my abnormal population are expressing this. So this is an immature neoplasm, an acute leukemia, and not a mature neoplasm. Your first job is this. Why? Because the treatment is basically based on this thing. Sometimes people stick like they are in fix what to say because none of these are being expressed. 55 is being expressed at a higher level, but still. So those are the very rare cases that you have to, that's not exactly 2 + 2 4. Then after saying that, yes, you have got an immature neoplasm, you have to classify this, whether this is AML or ALL broadly, because the treatment again based on AML and ALL are totally different. BLL, TLL are mostly treated similarly. AMLs are treated very differently. So you now classify it. Then your job is to prognosticate. Then your job is to have a therapeutic target. If you can say, because when the patient is not responding to first line therapy, second line therapy, they want to add some targeted therapy. So if you have expression of CD38, they will give daratumumab. If they have CD20, they will give rituximab, so on and so forth. And then you want to have certain markers that will help you in monitoring the disease, which is not normally expressed or expressed at a very low level in the normal counterpart, but those are aberrantly expressed or expressed at a very high level in the leukemia. So you have to differentiate these things, right? Now, if your lab is limited to only diagnosing a case as leukemia or not, you have a very small number of antibodies that you can use. Now, if your lab or your clinician expects from you that you say to me whether it's AML, BLL, or TLL, then you will have little more number of antibodies. When your lab expects that you should give us some prognostic value and provide us some therapeutic value, you add again further number of antibodies. And when your lab expects, when your clinician expects that you will monitor the disease subsequently after day 35, day 78, post-transplant, pre-transplant, then you should have certain antibodies in your panel that will give you and help you in disease monitoring. Fine. That's how the number of antibodies varies. So a smaller labs which are restricted can do the thing in 6 to 8 color tube, single tube. Different multiple labs which are also doing adding certain research to it, they have large panels, 3 to 4 tubes of 10 to 12 color each. Fine. So these are the panels, and how you design panel, you should be aware of at what level of my maturation my XYZ and expression is present. So if I say these are all mature cells, so what you see CD45 is dimmer. Here it's brighter. Fine. So you have certain cell, it's dimmer 45, TDP 34, these are not expressed in the mature cell. So if something is being expressed over here, you say that yes, my cell is immature. If you have expression of 45 bright, but absence of these expression, you can have the cells in these stages of maturation. Fine. So these plots you can see in the, if you type Woods, Brentwood et al. For the maturation, these you will give. Why I'm showing this? Because based on these plots, you are aware or you know that which marker is expressed at what level. And based on that marker expression, you say that your leukemia or your abnormal cell is mature or immature or in what stage of maturation. Because most of the classification is based on the stage of maturation where the cell looks like on immunophenotyping study. Fine. So then again, the next job is to assign the lineage. Fine. Whether it's BALL, TLL or something like that. So for myeloid, these are the lineage markers that are usually expressed, and MPO is the lineage specific marker. So if something is positive for MPO, it's straight away myeloid. If it is expressing 13, 33, 117, you say that it can be myeloid if it is not expressing another B or T cell marker, because expression of 13, 33 is common aberrancies in BALs and TLs. You cannot specify that this is my AML. Fine. Similarly, for BALs, these are the markers that are usually expressed, but no single marker is specific for BL. Fine. For T cells, these are the markers that are commonly expressed, and cyto-CD3 is the one specific marker. So if cyto-CD3 is positive and you are sure that this is true positivity, it's straight away T cell area. Fine. Then you have NK cells markers, then you have something with a monocytic differentiation, megakaryocytic lineage, erythroid, and so on. And based on these expression, you say that my leukemia is because of this. Now the next question, if lineage associated markers are seen and those are from two different lineages, few myeloid, few T, or few myeloid, few B, or few B and few T, then how you will define that this tumor is either mixed phenotype acute leukemia or leukemia A with aberrancies of B leukemia. So this is the classification. So if myeloid, when you want to say that more than two lineages present, it should have at least MPO, cytochemical or flow cytometry or immunohistochemistry. For monocytic, it should have at least two of these 5 markers at strong expression. Then only you can say that this is myeloid. Similarly, for B lineage, if you have strongly expressed CD19 with at least one of these markers, or weak CD19 with 2 of the other markers strongly expressed, then you say that this is a B lineage. For the T, cyto-CD strong expression is the thing, and strong means something which is similar to or more than that of normal counterpart. So the beauty of peripheral blood or bone marrow is that you have always normal cells, normal lymphocytes present over there. So we compare the expression of normal lymphocytes with that of the blast. Fine. So these are the markers that I talked about. Some markers will help you in prognosticating. That expression of this marker may have a good prognosis, expression of that marker may have a bad prognosis. And they tell you about the genetic association, that these are such a expression of CD19 and 56 in AML have more propensity of these tumors of having translocation 821, expression of CD25 in BLL have more propensity towards harboring a translocation 922 mutation, and so on and so forth. Fine. These are some of the therapeutic targets, their name that is used to be a. And then what in our lab we do, we don't know initially when the sample comes to you, you don't know that whether this is BAL, myeloid or something. If you see or not, then it's a separate story. Otherwise, you run this tube. So this is the first tube and what we say it as acute leukemia orientation tube. So if you see this tube has got TGT 34 and 45, these three things will define you, give you an idea whether this is a mature neoplasm or an immature neoplasm, right? So anything which is dim to negative to 45 will be the blast region. Anything which is positive for TET or anything which is positive for 34 are the blast. Now the first job is done with 45, 34 and TGT, that these are blast. Then you start classifying them. So it's strong 19 with cyto 79, this will give you a B. You have CD7 and cyto CD3, CD7 here, cyto CD3, that will help you in getting T. And then if these are not there, you have some 13 and MPO that will help out in at least telling you, yes, these can be myeloid or T or B. So this is orientation. This is not exactly having multiple antibodies. This is just 2 antibodies of each lineage and then 3 to 4 antibodies that will help you whether these cells are your immature cells or the mature cells. Fine. So your job is done. Then the next job starts. If it's a BLL, then we try to use the tube, which is kind of similar so that we can monitor it during the disease or treatment, which is similar to that of MRD tube. So if it comes out to be 19 positive, we put this B tube and B aberrant tube. If it comes out to be myeloid, we put myeloid and myeloid AML-MDS1, AML-MDS2. And if it comes out to be T, we use T tube. And if there is nothing like positivity, no positivity for MPO, cyto 79, 19, 7, which means that this is neither B nor T nor AML, probably. Then we put this tube, which is for undifferentiated leukemia. That will help you in getting whether this is acute megakaryocytic leukemia or not, whether this is blastic plasmacytoid dendritic cell neoplasm or not, and so on. Right? So this is the orientation that is being followed in our lab. Right? Got it? So first job, orient ourselves whether it's acute leukemia or not. If it's acute leukemia, it's going towards B, myeloid or T, and whether if it's B, then you have to add certain markers that will help you in getting the prognostication and markers that will help you in MRD monitoring. Similarly for T, and so you did this. Now coming to the scatter plots, you put acute leukemia orientation tube. Based on that, you proceeded further with the tube. So when we look at the flow cytometric plot, this is the first plot usually is the time gated plot that will help you in getting out any, it exactly tells you how your machine was stable during acquisition. If there is any blockage or something during acquisition, you get a gap between the time. So based on that, the next plot is FSC area versus FSC height. And anything which is at the 45-degree angle, meaning thereby the height and area is proportional together. No two cells are sticking together. If two cells stick together, either their height will increase as proportion to the area, or either the area will increase as compared to their height. Fine. So anything which is having similar ratio will be 45 degree, because we know that tan 45 is 1 or something. When the something relation between the two parameters is exactly same, it will come as 45 degrees. So we choose the singlets, then we plot FSC versus side scatter. This gives you about the granularity and the size of cells. So if you see all the cells are lying over here, there is no grands or hardly any grands. So what we see are the mononuclear cells only. And when we plot these on 45 versus side scatter, what we see, two group of cells. One lying over here, one lying over here. Forget for the time being about the color. So we have one group of cell over here, one group of cell over here, and some cells lying over here. So something which is very bright positive is CD45. Normally, you don't see anything in this region. Behind this CD45. So this is usually lymphocyte. If you are lucky enough, in a normal sample, you can see a small amount of population over here. This is your basophil, right? Then there is nothing in this region, fine. So anything which is lying in this region are suspicious population, which is known as the progen region or the blast region, where the progenitor lie. So can anyone explain, anyone who is having experience with flow cytometry? Fine. So can you please tell, these are the my population which I am interested in. Why am I interested in? Because normally there is nothing lying over here. So when something is not normally lying over there, I put this boundary which is known as gate, and when we put the gate, we automatically gives the red color. So my population of interest now are these red population. So can you explain the immunophenotype of these red population? Do you all agree that these are my abnormal population, or should I give something else? These are abnormal. Now this is what it is expressing. 34. It's expressing 38. It's nicely expressing. It's a nice round button 10 and 19. So we have 34, 38, 10, 19. Only till this point of time, what I can suggest. B. Write 19 along with any of 10, 22, CD79, any one of them as right. So we have 10 and 19 both right. So this is probably a B. Then we have CD20 over there and CD10 on this side. I think one slot is missing or what? No, fine. So this is CD20, this is CD10. So nice CD20, CD10, but CD20 is a little bit of heterogeneous. What you can see, this green population over here are your normal B lymphocytes. They are bright CD20 positive, but negative for CD10. That's how your normal B cells should look like. So you have this population positive for 20, little bit of heterogeneous, little bit of them. CD10 bright positive. Then you have CD73. Then you have CD123. Then you have expression of CD33 as well. Fine. So if to summarize, till this plot only you are convinced that this must be a BA. Fine. But you have certain additional antibodies CD123, CD73. Why these have been used for? Because these are my MRD markers that I am going to follow them up. So this happens to be in orientation tube kind of thing. These are my B additional tubes that I will do when I am convinced that this is a BLL. I need to follow them. Fine. So in summary, what these cells are positive for: CD10, 19, 20 heterogeneous, 34, 38, 73, 123, 304, and 33. So my diagnosis, it's negative for all these markers. So my diagnosis is B, lymphoblastic leukemia. Fine. Conventional karyotype was done. This case was 46XY. And then fish panel was negative for all these. So my, based on genetics, this is BLL-NOS, not associated with any specific marker. Fine. So this patient is now, so this is the first use. I diagnosed the case as BLL. Now this patient is admitted to ward, started with BFM 95 protocol. There you tap CSF to see whether your CSF is involved or not. What do you say? These are normal cells or abnormal cells? Little difficult to say on the screen, but looks like suspicious cells. If on the smear, these are the number of cells, then definitely it's very increased. And then you do flow cytometry, definitely on flow cytometry analysis of CSF, it's not too much of events, 10,000, 20,000 events, like very scattered dots. So what you see is you have blue dots over here, red dots over here. This color is because of these gates. But anyways, this is the plot what you see. You have 19 versus 3 because this is the first plot that we put. In CSF, mostly what you see is the T lymphocytes and the monocytes. Right? If you see B lymphocytes and that too in larger number, you should be suspicious. Now, if I get my B lymphocyte based on 19, what they are expressing is CD34. Now, CD34 is an immaturity marker. Fine. So 1934 positive, 1910 positive. So I am seeing my blast, which I was seeing in peripheral blood in CSF also. Fine. And how you say that this is not very much contaminated, because I hardly see neutrophils in those large number of, as compared to these lymphoid. So my CSF is involved in this case. What next? So this then patient is already treated with BFM 95 protocol. CSF is involved. CNS directed therapy has been done. Now, if you are treating a patient of ALL, post-induction, you have to do a marrow. to see that whether your blasts are present in the marrow or not. So this point of time, you do a morphological examination. What it says that morphological examination has only 2% of blast, not very much increase. So morphologically, if it's less than 5, you say that this is morphological remission, right? But you subject this sample to flow cytometric analysis. And what you see abnormal population lying over here. Why this is abnormal, we'll learn subsequently. Anyway, I told you in previous plot that CD73 I use for MRD, right? So normally CD73 is expressed in mature B cells and very few of stage 2 hematogones, not to this bright extent. But if you see, this case was CD73 expression. I go 2-3 plots back. So this is CD73 expression, fine? You're brighter than your normal B cells. So this CD73 acts as a marker, which if positive, I can say that these are not normal blasts. Normal B blasts do appear in bone marrow, and those are known as hematogones. So those normally do not express CD73 to such a high level, which is shown over here. So you have this large population of cells, which are the residual disease. You calculate this amount and you say that, yes, my MRD is positive, and what is the percentage? Based on your percentage of MRD, the treating physician may upstage the disease and give high intensive therapy, fine? Then treatments were intensified in this case because it was MRD positive and first point of time. This is the second time point when bone marrow was done. So you see, if someone is aware, this is the B cell precursor, which is showing a maturation pattern, which is known as hematogones. And I said these are the stage 2 hematogones that only slightly show CD73. Then it goes down. Then these are the mature cells which are showing CD73 expression. Just like previous slide, you don't have a large population sitting over here. So routinely what we do for MRD analysis, we put these things, this is known as template, we put a boundary around the population, and suppose that all my population, if it is lying inside, is mostly my mature, anything which is lying outside looks suspicious, and we have to analyze it whether those are exactly MRD or not. So first time point post-induction, this was MRD positive, treatment was intensified, then post consolidation, this becomes negative. Now this patient was planned for what is HSCT? Hematopoietic stem cell transplantation. Fine. So when hematopoietic stem cell transplantation is done, usually HLA matching is done. The best is 10 by 10 or 12 by 12 match. Many situations you don't get a match, then you have to do match with your father or mother, which is half match only, and that is known as haploidentical transplant. In haploidentical transplant, you have to see before transplanting whether that patient, suppose if I am getting transplant from my father or mother, there may be a chance that he or she, the donor, is having preformed antibodies against myself, or I am having preformed antibodies against his cell. So if his cell is transfused in myself and my serum is having antibodies against his cells, all the hematopoietic stem cell which is transfused dies off very quickly. Fine. So for this also, flow cytometry is used, which is known as donor-specific antibody testing. And this I'll not go into detail. So you check presence of preformed antibodies for the donors in the patient serum. Fine. When it is clear that, okay, the amount of DSA present is very less or absent, then you give a go green for the stem cell transplantation, and the stem cell transplantation is done. Now, how you do it? You put some injections to increase the stem cells in the donor. Those stem cells are mobilized in the peripheral blood, and then you count stem cells. Fine. And the counting of stem cells is also being done by flow cytometry. And then you calculate the dose. So this is just like the strategy. You identify these cells based on CD34 because hematopoietic stem cells committed hematopoietic stem cells are CD34 positive. They are Dimer 45 and they are higher in size as compared to lymphocytes. And these do not lie in the debris. So based on these 3-4 parameters, you identify the stem cells, and then sufficient number of stem cells is harvested from that donor and it is transfused to the patient. Fine. So these are some of the counts. But along with that donor stem cells, what you transfuse is also the lymphocytes which are CD3 positive. So the amount of these CD3 positive cells are also important in some situation where you want to transfuse to the patient when he is losing chimerism. This is like when donor lymphocyte infusion, these lymphocytes are used to suppress down your cytotoxic cell that are killing. So this is also being done with the help of flow cytometry. So with this case, what I wanted to highlight that flow cytometry is not only used for the diagnosis of leukemia lymphoma, but in leukemia lymphoma situation, it's also required for analyzing CSF involvement, for analyzing any other body fluid involvement, for doing MRD analysis, stem cell harvest, donor-specific antibodies, DLI, etc. So there is a wide spectrum of flow cytometry in cases of acute leukemias. Fine. So now quickly I'll show a few cases. So this is important plot with experience. What you see, so this is 45 everywhere. This is side scatter everywhere. Now, if you see, these are from different leukemia cases that helps you in telling that what can be the probable diagnosis based on a physical and 45 property that you know. So here I said these are the lymphocytes. These are the bright 45. Something which is passing through the middle of these neutrophils are the moderate 45, and something which is near the RBCs is considered as 45 negative. So if your any blast population is lying from here to here, it's moderate to bright. If it's lying from here to here, it's moderate to dim. If it is lying below this, you can say that those are negative for 45. Fine. And these are the scatter properties of AML. If an AML without too much of differentiation, AML without maturation, if it's there, sorry, AML without maturation, these are the large chunk of blasts that lie over here. Fine. This kind of plot you see with AML M4 kind of thing, where you see a proportion of blast over here, a large proportion of monocytes, then something with the eosinophils. So you have AML M4 EU. So this kind of 45 usually you see with the BAL. Fine. 45 negative, or sometimes if it's lying like here, some megakaryotic leukemia with a little higher size scatter over here. This, if you see a small amount of cells, lymphocytes over here, now your blast is almost sticking towards the lymphocytes. So this happens with TALs. TALs usually have a brighter 45 as compared to your lymphocyte, other blast. Fine. So this is the, yeah. Yes. So here what you see, you have a lymphocyte, you have these grams, and you have large population of cells over here. Right? So these kind of blasts, usually B blasts have complete loss of 45. Fine. B blast, or if suppose if it's a megakaryotic leukemia, now if I say the comparison of size based on SSC, the side scatter of this is a little bit similar to this, but in megakaryotic leukemia it goes like here, it's 45 negative megakaryotic, but the size is little larger as compared to this one. So every B cell doesn't happen. B cell usually, if you see, there will be a streaking from here to here. But if you see complete negativity loss of blast, that can be BAL, little bit higher can be megakaryotic leukemia kind of. Myeloid usually look like this or kind of this, sitting in this, a little bit away from the lymphocyte. T usually stick towards the lymphocyte. And in AML M4 kind of thing, you see multiple population. You see lymphocytes, you see blasts, some maturing promonocytes kind of thing, some monocytes, myeloid maturation, eosinophils, all these population you see with AML M4 kind of. Yes. Yes. Yes, sorry. Yes, it's BAL with eosinophil. So this, I forgot. So if you see, these are the lymphocytes. I told you, these are your myeloid population. Then little brighter 45, high cycle, you have a eosinophil. Now this case, you have this much of myeloid population, large amount of eosinophils over. Fine. And this was a pro-monocytic leukemia kind of thing. If you see, these are the lymphocytes, these are the myeloid, these are monocytic lineage kind of thing, going from here to here. monocyte. Your APML will lie something like a teardrop over here. Fine. So, yeah. Right. So now scatter plots only, I think history little bit. Start from this plot. Do you think this is normal or abnormal? So what we see a large population of cells lying over here, right? Something which is dimmer and moderately high side scatter. We give it a color, red color. Now you see what exactly it's positive for. Ashi, without Anshi, 34, 30, bolo, kuch to bolo. 34 positive or not? Positive. 19 positive or not? Let's go one by one. CD7 positive or negative? Negative. So 117 is a which marker I showed you the table? Myeloid. So 117 nicely positive, 19 also moderate positivity. So myeloid and B. 33 also positive. HLA-DR, a bright kind of thing. So till here, B lineage, myeloid lineage, or what? Pardon? We have to wait for him to, yeah. Yeah. So how do you decide? You can, this is my lymphocyte, I know. These are my erythroid, I know, but I don't know what are these cells because these kind of cell in normal plot, it's not like that. You can see a chunk of cells lying over here. So we can, what exactly, it's a lymphocyte. These are my myeloid come over here, my eosinophil come over here, my lymphocyte come over here. You see in this area, if it's a peripheral part of wound, there is, if I plot a complete plot or density plot, my major population lies over here. No, not exactly granules, yeah. It's a myeloid kind of thing, which is having a little bit of internal complexity, we can use here, nuclear control or the granules, and it's got a little bit of dimmer protein. So anything which doesn't look like normal in a peripheral blood or marrow, I gave this population, then I analyze. Fine. But while analyzing, it's not that you plot only red cells and leave all the other. Reason, if you plot only red cells, you will not be able to compare the expression. Whether my this thing is brighter 45 or dimmer 45 and so on. So I created these cells. Next set of plots. So 15 negative, 11B negative, CD2 negative, 123 positive. This is also 56 positive. Fine. CD4, I can say it's a unique kind of thing. Now, cytokine PO, positive over here. You have normal B lymphocytes lying over here to compare with CD3 negative. So you have AML with aberrant CD19 and CD56 expression. Fine. And this was the genetic translocation 821 that came out, and AML with translocation 821 frequently have CD19 and CD56 expression. Fine. Some cases are 19 only, some cases are 56 only, some cases are 19 and 56, and some cases even do not have any 19 or 56. But mostly if it's AML and expressing 19 and 56 or 19 and or 56, it's translocation 821. It's not like that. Aberrant population will have a bad prognosis, not like that. The prognosis usually depends on the genetic family. But that gives you a cue, immunophenotypic cue, that this patient must be having translocation 821. So if you have a facility to test, or the patient have facility to go for only one test because of financial thing, since you know that this is a good prognostic one, you go ahead with this, you don't go for NGS scan or other thing, and if it is there, you say. Yes, this will also help you in identifying abnormal population cells when you are following it up doing MRD analysis. Fine. So quickly, again I told, so This is plot. Now, if I say these are my lymphocytes, these are monocytes, these are glands. Now I have a huge population over here, which is literally abutting this. Fine. So I have abnormal population. I gate them out, and if I read 38, moderate, negative for 34, negative for 19 and 13. So it's not a BALL. It's positive for 99, negative for CD3. So what is your impression? Whether it's T or not? It's negative for CD3. Yes. So it's not about CD3, it's about cytoplasmic CD3. Now I said, see, this CD3 means surface CD3. You have put the antibodies on the surface of a cell. You have not gone inside. So to go inside, you have to use permeabilization to fix the cell, make holes so that your antibody can go inside. Because what happens that cytoplasmic CD3 is like synthesized inside the cell, when it is expressed, when all the AB receptors are formed, it is fully expressed on the cell surface. Before that, in the immature cells, it's inside the cell. So you have to go inside the cell to see that whether it's CD3 positive or not. So, yeah, when it was CD3 negative. Now this plot, 4 positive, 8 positive, dual positive, CD5, CD2, CD7, and this is what your cyto-CD3 looks like. So this is nicely positive for cyto-CD3 and 4-8 double positive, negative for surface CD3, negative for 34. So this is a T leukemia. So the lesson learned is that TALLs are frequently CD34 negative, number one. TALLs are surface CD3 negative, but they should be cytoplasmic CD3 positive. Fine. So again, my abnormal population, these are my lymphocytes. These are my abnormal population. What are these positive for? Negative for 10, 19, positive for 34, 38, 13, 33, both positive. What it can be? We have not seen any T markers yet, right? So 13, 33, we do not have MPO as of now, and it's positive for 34 and 38. Then CD7 positive, HLA-DR and 117 negative, 99 nicely positive, 99 positive. This is CD3, this is surface, so surface CD3 negative, CD5 moderate, CD2 negative, and then 4-8 dual negative. What these purple populations are? Your normal T cells. So these are 4 here, 8 here, fine. So this red or orange population, which was abnormal, is negative for surface CD3, negative for CD4, CD8, negative for CD2, dimmer CD5. As compared to these cells, these are, this is your negative for CD5, this is your positive for CD5, right? Now this orange cells lies something in between. So this is positive for CD5, but much dimmer as compared to your normal population. Right? Now this is CD79 and this is cyto CD3. So what is the diagnosis? It's TAL, but the special type of TAL, it's 4-8 dual negative, 5 dimmer to negative, and presence of 13 and 33. Myeloid, positive for 34. What is the name of this type of TAL? Early thymic precursor TAL. Knowing this is important because this type of TALs behave more badly as compared to the conventional TAL. So you need to transplant them as soon as possible. Yes. So this is again a case. Focus on, this is lymphocyte. These are your abnormal population that you get and say as blast. Now what these are positive is CD34, 117 negative. So one important myeloid marker negative, it's heterogeneously positive for 33, right? Negative for 19, so not a B blast. CD7 is very dim positive in very few proportion of cells, majority of cells lie over here. It's negative for 64, 11B, negative for 56, negative for 20, negative for 4, negative for 5, positive for 123. So till now, it was positive very dim for 7, positive for 33, and positive for CD123. negative for 19, so not a B, negative for HLA-DR2, etc. These are the cytoplasmic markers. So this is cyto CD3. This population is positive or negative? Negative. You have, so this is, ignore this. These are the myeloid cells which are wrongly sticking to CD3. So you have normal T cells flying over here. This red population is negative for both MPO and cyto CD3. Negative for cyto 79 TDT, negative for 4, negative for 8, negative for 41. So positive only for CD33, CD7 very dim, and nothing else. MPO, all the lineage specific markers are negative. So what I told, if everything is negative, then you choose acute undifferentiated, where you add erythroid markers, megakaryocytic markers, BPDCN, etc. So for BPDCN, it should be positive for CD4, CD123, CD56. So it's not yet positive for anything. So what you will say? So these are all the markers that were positive. Fine. Nothing lineage specific, nothing to comment upon. All these 41, 304, 56, 16, 36, everything is negative. So not exactly fitting into any of the lineages. What do you call these? Huh? So it's acute undifferentiated leukemia. You cannot say or you cannot classify which leukemia exactly is. So before saying AUL, you have to put all the markers of B, T, myeloid, everything together, right? So this is again similar kind of cell, which is negative for 34. This is positive for CD36, very dim. Negative for 19, everything together. All the markers 117, cyto CD3, CD7. If you see, CD7 is negative. CD7 is very important marker for T. Most of the T alleles are CD7 positive and to a brighter extent. So if something is totally negative for CD7, it's very unlikely for that case to be a T allele. If the cell is totally negative for CD19, it's very unlikely for it to be a B allele. Fine. So similarly, similar to the previous case, this case was negative for each and everything. But if you see, this is positive for cyto 41 and cyto 42. And these markers are for megakaryocytic markers. And this is also positive for CD9. Fine. So this is then this one. This must be because of some gating. Sometimes when you gate, and especially during processing of cytoplasmic tubes, what you do because of your permeation, some cells from the myeloid come down, and when you put a gate based on the blast, based on load side scatter, some of the myeloid cells go down. So along with those blasts, few myeloid free cells also come in that gate, and those are seen as few scatter slots in MPU. Got my point? So your blast is like over here. This is the surface staging which I am showing. When you permeate these cells, all these glands may come over down. And if these are your pro-myelocyte or myelocyte kind of thing, this will also come in this gate. So now those few dots will show MPO positivity. So you have to ignore these dots. Your major chunk lies over here. Right? So this is kind of just a representative case similar to the previous one. Blast cell flying away, 34 positive. This is 10 positive, HLA-DR right, 123 right. Fine. And then negative for MPO, negative for cyto CD3, negative of everything. But it's nicely positive for CD123, 56 is very dim. It's also positive for, I think, where is the flow plot? So anyway, negative for everything. So we have to rule out acute erythroid leukemia, megakaryocytic leukemia, and BPDCN. So BPDCN by default will be positive for CD4, CD56, CD123, CD304, CD303. So 2 or 3 of the markers between them, if strongly expressed, you should strongly suspect these patients. These patients frequently have skin lesions, but it's not necessary. Fine. So I'll just quickly show one last case. This is the case, some learning experience 8 to 10 years back. That's why I'm showing you. So this was the case of a 21-year male patient, very morbid obesity. And these were kind of cells that we saw on the peripheral layer. Fine. Any suggestion morphologically? Right. So to us, also looks like it's a kind of promonocytes, monoblast kind of cells. So we went ahead with flow cytometry. And if you remember in the few plots, I told that monocytic leukemias come from here and it goes like this. Fine. So we then started seeing large population of over here and we gated them in blue. Then what we did? We plotted those on these plots. So what exactly expressing? It's nicely positive for 1333, nicely positive for 34. 19 is expressed moderately. This is 11B positive. This is little bit of comp issue over here. Nice positive for HLA-DR. So 13, 33 HLA-DR and 34 positivity. 19 was also positive, but it was negative for CD10 and other B cell markers. MPO was probably negative in this case. So we made this case as AML with CD19 expression. Jasmita madam is saying no. In saying this or something else that we are missing. Huh? So can it be BALL? All were negative. Everything. 19, 79, 22, 20, everything was negative. Right? So we gave this diagnosis. We are wrong here, but it's not because of we have not tried. We tried everything. It was positive for 19, 13, 33 positive, negative for MPO, dim for 64, and rest all the markers were negative. MPO was negative probably. Anyways, so we gave this diagnosis. Patient was treated for 1.5 years. The patient was fine. 1.5 years later, he presented with this kind of blood picture, increasing leukocyte count and presence of these kind of cells. Now, if I ask these blasts, do they look like similar to the previous blast or not? They do not because they have very little cytoplasm and more or less they look like myeloid or say smaller blast. There were no granules in that exactly. They look like lymphoid blast. Fine. So we did flow cytometry analysis. What I told, usually the B blast starts from here and goes till here. Right? So we found such abnormal population. If you see, nice lymphocytes, neutrophils, and your whole blast population. We gated these cells. Now what we see? These are 34 bright positive, negative for 20, 38 heterogeneous, 19 is positive but dimmer as compared to these normal lymphocytes lying over here. This is 10, very bright 10, right? And then 1333 negative. Earlier blast was 1333 positive, CD10 negative. So this is a totally different set of blast. So with this positivity, 19, 34, 10, HLA-DR, CD79, nice positive. What is the diagnosis? BALL. Fine. Now the question was whether that patient is relapsing or having a different kind of leukemia and is being treated for AM. The point that I wanted to highlight in this case is we gated these cells and showed only these cells in the plots. We forgot about other cells. And other cells are important because I told you have to compare the thing. Fine. So when we saw this was a query, we went back and saw the slides. What we found that in the diagnostic sample, 19 was positive in its blast, but we found in population 9 right over here, which was very bright for 10 and dimmer for CD19 as compared to these things. So this was a diagnostic plot, which was 34, 19, 13, 33 positive. We remember about negative for CD10, 79, 22. So we called this population AML with CD19. But when we plotted all the population on this, there was a small population which is bright CD10 positive, slightly dimmer 19 positive, and this was negative for 13, 33 and other things. So this was bright 10 positive. If you see, these are lying in the negative region mostly, negative for 1333, and this is dimmer 19 as compared to this population. So in toto, we missed this purple population in our initial plot, and this is the purple population that relapsed as DA. Because the phenotype of this population, like having bright 10, dimmer 19, was similar to that what we found at relapse. These are not mature, these are lying from CD45 region. These are from this region, not this. So initial gate is these blast, not the purple one. Fine. And those are positive for 19, bright HLA-DR 10. So what we did in earlier diagnostic sample, we plotted only these things. So we missed these plots. And we saw these populations said that this is AML with 19. But exactly what we missed is this small population. And this was actually to start with mixed phenotypic acute leukemia with B and myeloid component. Of course, the myeloid was on higher side, more number of cells. But had we said it, the treatment might would have been a very different, because like MPAL is still no standard of care. Some people try to treat it like ALL protocol, because ALL protocol is longer, so it may cover both the component, but some people treat it based on the which component is predominant. If it's myeloid 90%, B only 5%, probably they will go ahead with the myeloid. But at least we could have said, and we could have aware of this situation if we are monitoring the disease. Fine. We will now, in this case, we will try to find out the residual disease of both myeloid and B component, not only myeloid component. Because if we know that this is AML, we will put the tube directed towards myeloid, not B. Fine. So I will stop over here, and I have taken longer time, I know, but the message that I wanted to convey is that flow cytometry is an indispensable tool for any lab which is dealing with leukemia lymphoma. It's not only for the diagnosis, but also for many things which are associated with leukemia lymphoma immunophenotyping. Fine. And definitely, the final message is all of you should think, you should not think that this is a very fancy technique and this is very difficult. Everything is easier once you start doing that. It's not difficult. There are many challenges that you face, even Kunal, Prashant, and all those people, Dr. Jasmita, who are doing high flow cytometry, might be facing problems day in and day out. So you have tools to solve them, and when you start doing them, things become easy. So anything, even this wooden table, if you can mince it and make single cell suspension, you can do flow cytometry for that. With this, I thank and request Dr. Jasmita to come and take over.